Okay, today let's discuss the smallest stent that has ever been placed in the human body, the iStent. It's a minimally invasive glaucoma surgery. It comes under the subtype of minimally invasive glaucoma surgery, and in fact was the first MIGS that was available to ophthalmologists and glaucoma surgeons. So a few common characteristics across all stents. They are heparin coated so that they act in an anticoagulant fashion. They don't serve as a nidus for infection, inflammation, and clot formation. They are made of surgically grade titanium. Why titanium? Because it is MRI safe, it is non-ferromagnetic. So even after having such implants, unlike some other implants in the human body, such as maybe a cardiac pacemaker, patients with iStents can undergo MRI safely. The first generation iStent was FDA approved in the year 2012. It is no longer in use, at least not very widely used in clinical practice. However, just for academic purposes to know, it was about 1 millimeter long, and the opening that was present was 120 microns. In the year 2018, the second generation iStent came in, and it was called the iStent Inject. The reason why it was called the Inject is because it just needed an injection into the trabecular meshwork. You need not have to do any maneuvers to set the stent in place, compared to the first generation, where in the first generation you had to maneuver it manually into the trabecular meshwork, which would lead to a lot more complications and less repeatability of results, whereas the second generation just inject into the trabecular meshwork and leave. So where do you want to place these stents? It is always and always in the trabecular meshwork that you want to, the pigmented trabecular meshwork, where you want to place these stents. So the second gen that is currently in use has a main opening of 80 microns, 4 smaller openings of 50 microns each in the head which lies in the Schlemm's canal, a thorax which should be lying within the trabecular meshwork and should span the length of the width of the trabecular meshwork, and a flange which should be visible into the anterior chamber. The total length 360 microns, which means it is roughly 1/3 the size of the first generation iStent, and a width of the flange of 230 microns. Recently, a newer modification called the iStent Inject W meaning wider, has been introduced into clinical practice. The only difference is that the flange width instead of 230 is 360 microns. Why was this introduced? It was thought that 360 microns would give better visibility and better control over the device at the time of injection. Hence, a W stent has been introduced. Other than the width of the flange, everything else remains the same. So when can you use an iStent? Well, you need to place it in the trabecular meshwork, so it has to be an open angle glaucoma. Which varieties of open angle glaucoma? You can use it in POAG, you can use it in pseudo exfoliation glaucoma and pigmentary glaucoma. Two prerequisites that you have to have before considering an iStent is that the glaucoma needs to be mild to moderate. Why does it need to be mild to moderate? Because the efficacy of the reduction of IOP is about 3 to 4 millimeters of mercury. And if the patient is a patient of severe glaucoma where the IOP needs to be reduced by much more than that, then an iStent is going to be inadequate. It has to be a mild to moderate glaucoma, and it needs to be controlled on ocular antihypertensive anti-glaucoma medications. Ocular eye drops, it should be controlled on eye drops. You shouldn't have had to do a laser or a surgery before. And the second prerequisite is currently it is widely practiced along with phacoemulsification surgery. Why is that done? Because after the phacoemulsification, the IOP is reduced as well. After you extract the cataract, the IOP goes down. Additionally, it also gives you better visibility of the trabecular meshwork, because now the bulky lens has been replaced by a much smaller intraocular lens. A modification of this is the iStent Infinite, in which instead of 2 devices, which is the traditional way to perform iStent surgery, 3 units of the iStent are placed and no concurrent phacoemulsification is carried out. Early clinical trials show promising results. However, currently the best way to do an iStent implantation is along with phacoemulsification surgery. When will you not do? Again, it seems pretty obvious that if the trabecular meshwork is not visible, you cannot perform an iStent surgery. You cannot implant an iStent at a place where the place is not visible at all. So any form of angle closure, absolute contraindication for an iStent surgery. any neovascular glaucoma or inflammatory glaucoma, any chronic inflammation in the eye, you cannot place an iStent because the inflammation is very likely to block the iStent opening and failed surgery is the outcome you would get. Any condition with raised episcleral pressure, such as a thyroid eye disease or any other condition where the superior vena cava syndrome or anywhere where you'll get a raised episcleral pressure, is going to be a contraindication for the simple reason that the iStent is not a valved stent. It allows two-way access to the fluid. So ideally you want the aqueous to exit the eye, but if the episcleral venous pressure is raised more than the IOP, then there is going to be a reverse flow into the eye. There is going to be a hyphema coming, the blood coming into the eyeball. So hence an episcleral venous pressure raise is an absolute contraindication. And finally, if the cornea is not clear, you are not going to have a good view of the angle structures. So a hazy cornea, a case of corneal edema, a case of corneal opacity, any pathology of the cornea that is hindering the visibility of the anterior chamber structures, you cannot place an iStent. A basic prerequisite to estimate whether the surgery is going to be a success or a failure is to decide the washout IOP. Washout IOP is basically the IOP of the eyeball when the eye is not under the influence of any anti-glaucoma medications. You stop all the anti-glaucoma eye drops, wait for a few weeks, and then see the IOP. That is the actual IOP of the patient. So you can understand this is another reason why iStents can only be done in mild to moderate glaucoma, because the damage that measuring an washout IOP in severe glaucoma is going to be significant. Patients of severe glaucoma cannot tolerate a lot of variation in the IOP. You cannot afford to stop a patient of severe glaucoma on any anti-glaucoma medications for any duration of time. And that is another reason why iStents cannot be performed in severe glaucomas. It's only possible in mild to moderate cases where stopping the anti-glaucoma medications for some time does not cause as much of a damage. So what are the washout periods for different drops? For carbonic anhydrase inhibitors such as dorzolamide, brinzolamide, 1 week. Alpha-2 agonist, brimonidine, apraclonidine, 2 weeks. For beta blockers such as timolol or prostaglandin analogs such as latanoprost, travoprost, bimatoprost, you have to wait at least 1 month for the washout IOP readings to be accurately assessed. So, coming to the procedure, since it is combined generally with phacoemulsification surgery, it can either be performed before phaco or after phaco. Each has its advantages and disadvantages. Before phaco, the cornea is likely to be clearer, especially in a novice or in training surgeon, or if the cataract grade is higher. After phaco, the advantage is that since the lens is removed and the IOL is of a much smaller size than the natural crystalline lens, especially a high-grade cataractous lens, the anterior chamber is likely to be deeper and trabecular meshwork visibility is much better. So the advantage of after phaco is a disadvantage of before phaco, meaning if you perform an iStent surgery before phacoemulsification, then the trabecular meshwork visibility is going to be much lower. And similarly, if you perform an iStent after phaco, the cornea is likely to get edematous, the cornea is likely to get swollen, and hence visibility could be hindered. It is a personal choice as to what exactly a surgeon wishes to do in terms of the sequence, but generally the most common method is an after phaco surgery, because the machines we use, the techniques we use now are less likely to produce a corneal edema, and hence first the phaco is done and then the iStent is injected. 2 maneuvers we need to do to ensure good visibility of the angle structures. The patient's head needs to be tilted away from the surgeon and the microscope needs to be tilted towards the surgeon by approximately 30 to 45 degrees. The angle that this produces allows a better visibility of the nasal trabecular meshwork, the nasal angle structures. Always remember that iStent Inject is done under direct gonioscopy. Why gonioscopy? Because the angle structures are normally not visible. They undergo a total internal reflection, a TIR. The light rays coming from the angle undergo a total internal reflection. So what do? You eliminate the air tear film interface and you introduce a gonio lens tear film interface, which eliminates the total internal refraction, and then you see the structures of the angle. Why direct? Why can't you do it under an indirect gonioscopy? The basic difference between direct and indirect is that indirect will invert the gonioscopy structures And that inversion is a very big source of confusion when you are injecting a stent of size 360 microns. So a direct is always preferable, a direct surgical gonio lens. You say, for example, the patient's left eye has undergone phacosurgery and now you want to implant the iStent. The iStent is approached from the temporal clear corneal incision, the same incision from which phacosurgery was done. So a separate incision is not required. You place it in the inferonasal and the superonasal quadrants, which are about 2 to 3 clock hours apart. So why are two stents used? Why can't we use just one stent? Now, surgical results, the clinical results that have been found in studies is that a single stent placement produces an outflow increase by about 0.38 microliters per minute per millimeters of mercury. Placing two stents almost doubles this to 0.78, wherein one stent does about 70% of the drainage job and the second stent does about the rest 30% of the job of draining the aqueous from the anterior chamber. Now, why can't we just have one single large stent? That is because the trabecular meshwork size limits the opening to which we can have the stents for. Currently, the main opening is about 80 microns, which is roughly the width of the trabecular meshwork. Any increase is going to just either place the stent into the non-pigmented trabecular meshwork or into the scleral spur, which is not going to be useful. We need to target the trabecular meshwork because that is where the aqueous drainage is happening most of the time. Post-surgical management, do not restart the anti-glaucoma medications immediately. Why? Because we need to know whether the surgery has been a successful surgery or a failed surgery. We need to know whether the iStent is working for the patient. We wait for some time for the surgical inflammation to go down, maybe 3 weeks, maybe 4 weeks, and then we assess whether this patient needs to be restarted on anti-glaucoma medications. Rest of this care is similar to post-operative cataract management. You start antibiotics, you start steroids, you start NSAIDs, oral and topical such as Nepafenac as and when required. So what could go wrong in an iStent? Well, it's a stent. It can have malpositioning. It is possible that at least in the initial stages, the surgeon might misidentify some other structure in the angle as a trabecular meshwork. Very often it is the ciliary body because both are pigmented structures. It is very easy for a ciliary body to be mistaken for the trabecular meshwork. The stent can undergo obstruction. Either it is because of blood which oozes out from the stent or from the surrounding structures, or it could be because of inflammatory cells. There could be hyphema. The source of hyphema could be raised episcleral venous pressure itself. And this hyphema is actually a good sign. A very small amount of hyphema is a good sign because that indicates that we have hit the trabecular meshwork very well. We are in place. But too much of hyphema is going to produce a raised intraocular pressure and a possible obstruction of the stent as well. And finally, like any stent, it can undergo either a dislocation, which is a complete removal from its original location, or a subluxation, which is a partial migration either into the trabecular meshwork or outside into the anterior chamber. In either of these cases, the best investigation to perform is an ultrasound biomicroscopy to confirm the location of the stent. How does it rank in comparison with anti-glaucoma medications, the topical eye drops that we traditionally prescribe? Well, the advantage is that the patient now no longer has to use eye drops. Understand that glaucoma is a lifelong disease, so the patient has to continue the topical medications for lifelong. So if a single stent is going to eliminate the requirement of eye drops, then it is a major advantage over the traditional eye drops that we prescribe. And secondly, many of these topical eye drops have surface toxicity. They have preservatives or their own constitution, such as the alpha-2 agonists, which produce allergic conjunctivitis, is a major disadvantage of topical eye drops. So the stent eliminates this problem. The disadvantage is it is a surgical procedure. Nowadays, combining it with phaco is eliminating this disadvantage to a certain degree, but it still requires manual ability. It still requires dexterity to master. The major disadvantage is cost. In a country like India, one iStent injection costs about 1.5 lakhs per eye. That comes to about 3 lakh rupees for both eyes if it is a bilaterally symmetrical mild to moderate glaucoma. That is an extremely expensive affair. One might argue that the cost of eye drops will reduce And over a long period of time, this stent will turn out to be a more profitable option, a more cost-effective option. However, it is possible that with time, the glaucoma might also progress from mild to moderate to severe, thus making the iStent useless in such conditions and requiring the patient to go back to either eye drops or any other surgical management. So if the cost can be brought down, it would be a major breakthrough for these iStents. So how have they been performing? How have iStents been doing? Well, after phacoemulsification, the IOP usually reduces by 3 to 4 millimeters of mercury on an average. After an iStent, it reduces by 3 to 4 millimeters as well. So on an average, after an iStent plus phacosurgery, the IOP should reduce by 5 to 7 millimeters. Why is it not an arithmetic combination of just 6 to 8 and why is it 5 to 7? Well, there are factors that we still don't understand. Maybe some inflammation, maybe some foreign body reaction, something like that might be reducing the efficacy, but nevertheless, it is a decent option for mild to moderate glaucoma. And in most patients, it has been seen that if you perform a phaco plus iStent, the requirement of anti-glaucoma medications reduces by at least one eye drop. So if the patient has been using 3 eye drops, now he requires 2 or 1 or none at all. So that has been the advantage of iStent. It at least reduces the requirement of anti-glaucoma medications, if not eliminate it completely. So what's next in the iStent injection procedure? Well, there's a third generation stent which is expected and is going to be marketed as a stand-alone procedure, which means the efficacy is going to be maintained without a phaco surgery required along with it. It's just a stent procedure. You don't need to do a phaco with that, which means that it has potential to be used in clear lens patients who do not have a cataract yet. And finally, there are research methods that are being used to reduce the cost of manufacturing, marketing, and distributing the stent. Hopefully, in the near future, this becomes a more mainstream method of managing mild to moderate glaucoma. One major disclosure for this entire video: I have used names of several instruments, several techniques in this video. I hold no financial interest or no personal interest in any of the methods that I have spoken about in this video. The names have strictly been taken for academic purposes and teaching purposes alone, and I do not receive any remuneration from the manufacturing company or anyone else for this video. To understand the iStent technique in much more detail, there are surgical videos given in the description, links of which have been provided. Thanks for watching the video. I hope you liked it, and I hope to see you very soon. Thank you so much.